Okay.
All right.
Margaret Perkins, 469.
Wait, Miss Perkins, don't call out your number just yet. I'll let you know if we can't find it, okay? I'm just doing that because there's a lot of you on the line, and I don't want to miss someone. And if we can't find you, we'll let you know, okay?
Okay.
All right. Good morning.
Good morning.
Good morning. Good to see.
Oh, good morning.
Good morning. Good morning.
Hey, everybody.
Good morning.
Hello.
Good morning.
Good morning.
Good morning.
Good morning.
Good morning.
What are you talking about? My goodness.
Good morning.
Good morning.
Good morning.
If the phone rings, just let it ring.
Good morning.
Good morning.
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 Good morning, everyone.
Good morning to you.
Morning.
Good morning, Loretta.
Melanie.
Yes.
Good morning, Juanita.
Who is this? Since I'm on my phone and can't see anybody, who just said good morning?
I can't see anybody.
Marie.
So that's why I said good morning, Loretta.
This is Marie, Juanita. This is who? Marie. Good morning.
Good morning.
I'll be glad when I can sit back at my computer so I can see everybody.
Yeah.
How's everybody doing?
Well,
Good.
we're doing real good. Considering everything we're doing, I think we're doing good.
I'm waiting for rain to go away so that we can experience some fall weather.
Oh, yeah. Mm-hmm.
Anybody been out to the fair?
No.
I have.
No.
I have. No. I have.
Good morning. I'm a night.
I'll be going this afternoon. This
Okay.
afternoon.
Oh, I haven't been.
You haven't been, Miss Freeman? So who said they're going this afternoon? You gonna get a turkey leg or a corny dog? Or both?
No, I'm not.
All three of them. All three of them.
Oh, me.
Turkey leg, corny dog, and the funnel cake.
Okay. Oh,
Yeah.
the trifecta.
Yeah,
The trifecta.
that sounds good. Yeah. Anyway, I
Good
can
morning.
go. Good morning.
Morning.
Good morning.
I'm a
Good
night.
morning.
Hi, Miss Knighton. We got you.
Okay. Thank you.
Good morning, Silver Palmer.
Okay.
I'm sorry, you asked who was going to the fair, and I didn't say my name. Rosa Gonzalez,
Okay,
a
Miss
foster grandparent
Gonzalez.
volunteer.
Morning. Good
I hope
morning.
you enjoy, Miss Gonzalez.
Good morning.
Good morning.
Good morning, everybody. Good morning.
Good morning.
We are trying to get you all locked in. Make sure we got everybody listed.
Okay.
If you all could do me a favor and put your lines on mute for me.
Good morning.
Good morning.
Good morning. Phone on mute.
This is Miss Wade.
Hi, Miss Wade.
And I'm Bobby Freeman.
Miss Palmer, is Miss Gibson with you?
Yes, I'm here.
All right, Miss Gibson, I got you. I've got you. I got you too, Miss May Gibson.
Melanie, I'm coming to Miss Packer.
I'm sorry, I couldn't hear you.
Melanie, am I coming through, Miss Sasser?
Yes, ma'am. I see you, Miss Sasser.
Thank you.
You're welcome.
You want us to put it on mute now?
Yes, please.
Okay.
Well, I was muted, but
If you're on the phone and you're trying to mute, hit *6.
Okay. Melanie, did you get
somebody,
any?
someone is on a Galaxy A11, and I'm not sure who that is. If you can turn on your camera, because it looks like you're on Zoom. We just want to make sure that we have you in, okay?
Good morning.
Good morning.
This is Patricia. Patricia Cornell.
We've got you, Miss Cornell.
Good morning.
Melanie, do you have these? Melanie Martinez?
Yes, ma'am.
Okay.
In just a minute, I'm going to go through the numbers that I don't have. And if I don't call your number, that means I've got you locked in, okay?
okay.
That may be Miss Tiggs on that Galaxy.
Oh, okay. There's another one too. There's a they're trying to turn on their light. Let's see. I can't see who that is.
Good morning.
Good morning.
Good morning.
I think, do we have just about everybody?
You have me, Melanie, because I came in on Zoom and I backed out.
Yes, Miss Henry, I've got you.
Oh, yes. I came in on Zoom, but I didn't see anyone but you, so I backed out and went online. So,
Miss Branch, is that you on? Wave at me, Miss Branch. That's you. Okay, I got you.
Good morning, Melody.
Good morning, Miss Martin. How are you?
Doing pretty good. I'm hopping today.
Uh-oh.
Good morning.
Good morning, Miss Flores. Okay, I think we've got everybody in. Okay, good job. So y'all, we've so to our senior companions, this is our normal meeting time, but I wanted you all to know that we have some special guests in the room. We have several foster grandparent volunteers joining us for today's call. So let's give a warm welcome to them. Thank y'all for joining us today. And then we have our esteemed guest, Dr. Angel, is here to talk to us today. So I'm going to spotlight Dr. Angel so that she's the face that you all see. I saw her surprise face when I said that. But she's going to be presenting to us this morning, and I'm going to turn it over to Constance to do an introduction.
All right. Hey, Dr. Angel. Well, good morning, everyone. Thank you, guys.
Good morning.
Good morning.
Morning.
Oh, we're so happy to have Dr. Angel back with us. She presented before to our senior companion group and with rave reviews. Everybody loved her presentation. So we're very glad that she was able to come back and visit with us again to talk to us about breast cancer awareness.
Excuse me, Constance. You sound kind of muffled.
I'm trying to mute people. I think that's why you all can't hear Constance. So I'm going to go through and try to mute people so you can hear her better.
Hi, Miss Melanie.
Hi. If you all are not
There's a
muted,
little kid.
good morning, Miss Tiggs. If you all are not muted, if you could mute your line, that way everyone can
All
hear
right.
the presentation.
Let me put my headset on and see if that's better.
That is a lot better, Constance.
Okay, so I'll tell you guys, that's better? Okay, great. I'll tell you guys a little bit about Dr. practicing with women's health specialists in Dallas and Rockwall, Texas. Originally from Southern California, Dr. Angel pursued her passion for medicine and attended the University of California, Los Angeles. While there, she completed an accelerated 7-year program that combined college and medical school. In 1994, Dr. Angel moved to Texas for her residency at the prestigious Parkland Memorial Hospital, University of Texas Southwestern. In 1998, Dr. Angel joined the compassionate team at the Women's Health Specialists of Dallas. Her medical specialties include obstetrics and prenatal care, gynecologic surgery, and treating infertility. She also specializes in treating menopause and helps women through all transitions of life. For multiple years, Dr. Angel has earned Living Magazine's Best of Reader's Choice Award for her work as an OB/GYN in Dallas and Rockwall, Texas. She is also celebrated as a mom-approved women's doctor in Dallas Child Magazine every year. Residing in Rockwall with her husband, their daughter, and their 3 sons, Dr. Angel enjoys spending time with her family. Her goal is to love her medical career even more in 50 years than she does today. I think she'll make that goal. So welcome, Dr. Angel. Thank you for joining us. Take it away.
Thanks, everybody. Of course, I'm going to share some slides, and that way it just will give a little bit of visual to hopefully those of you who can see it. Those of you that are listening, I'm just going to be talking about the same thing, so don't feel like you're missing out on anything. But I'm going to share my screen. We've all become very Zoom savvy. Can you guys all see that? Yep, thumbs up. Okay.
Yes, yes, it can.
Awesome. Okay, let me go back over here. So as we all know, October is Breast Cancer Awareness Month. You're going to see pink everywhere. You're going to hopefully be wearing pink ribbons in support of those that are fighting and those that needs our support. So that's why I was asked to talk about breast cancer. But we're going to talk about screening for breast cancer. We're not going to talk about treatment or diagnosing, because I am an obstetrician gynecologist. I'm not an oncologist, and I'm not a breast surgeon. But when you take care of women every day, of course, breast cancer is something that I talk about on a daily basis, mostly on the screening side of things. So here's a few statistics. 275,000 women are diagnosed each year in the United States with breast cancer. And the latest statistic shows that we have 4 million breast cancer survivors in the United States currently. So that's an amazing amount of numbers. And I think that's a testimony of our treatment, and our statistics are going to apply to you that I wanted to read out. Most of our breast cancers are actually over the age of 50. Average age of breast cancer diagnosis is 62, but 20% are over the age of 75. And with our longevity extended out to our mid-90s now, that's a big portion of our population. So we don't want to stop our screening when we get to a certain age, because we've got so many more years that we're at risk. It is the most frequent cancer diagnosis for women over the age of 60, and it affects 1 in 8 women in our lifetime. So I just looked at the total, and I think we've got about 60 some odd patients, or 60, sorry, I'm working today, so I got patients on my mind. But so if we have 64 people on our Zoom call, if you do a little bit of math, that means that we are going to have about 8 of us that are going to be affected by breast cancer personally. So just kind of puts it into perspective. So the 1 in 8 has been the statistic for a very long time. The more women we have on the planet, the more women we have in the United States, the more women that are going to be affected. So 1 out of every 100 breast cancers, though, is a male breast cancer. And that surprises a lot of people. They don't even think that men can get breast cancer, but they still have breast tissue as well. And does anybody out there, does anyone know of a male that's had breast cancer? And raise their hand if they've ever known of anybody. I've had several patients who've had either a father or a brother who's been diagnosed with breast cancer. And unfortunately, all the attention is always on women. But we do need to be cognizant, that there is that history as well. And that puts their family members at a very significantly high risk. Just to give you an example, if you have a father who has a breast cancer, you have a 50-50 chance of a female relative having breast cancer as well. So even though the chances are higher over the age of 60 of being diagnosed with breast cancer, the chances of dying is very low. Right now, our 5-year survival rate, which is how we talk about cancer, is 90%. And why is our survival rate so high? It's because of screening. Because the earlier we find a breast cancer, we have the greatest chance for a successful treatment. Again, there's 4 million breast cancer survivors in the United States, just in the United States, not worldwide, but in the United States, because our screening has advanced so much. Whoop. There we go. So early detection really does save lives, and that's what we're going to talk a little bit about today. So what is our screening that's recommended? So it is recommended that women starting at the age of 40 will have a clinical breast exam every year. I see a lot of young patients as well. I see teenagers all the way through 20s and 30s, and I do a clinical breast exam on every patient every year. And what I tell my young people, my 18-year-olds, I tell them, I'm teaching you how to do a breast exam so you can start practicing, because you need to know your anatomy. You need to know what's normal for you, because you're with your breasts 365 days a year. I'm only there 1 day a year. So I teach patients at a very early age to do a breast exam. So, but it is recommended that every woman over the age of 40 have one done every year by a clinician. And that could be your primary care doctor, could be your internist, could be your gynecologist. Mammograms are currently recommended for all women every year from the age of 40 until the age of 75. And we'll talk about that in a minute. And then the question comes up, what about self-breast exam? Remember those little cards that they gave you and you hung it on your shower and it was supposed to remind you to do your breast exam? A couple of years ago, they came out with a recommendation to not do self-breast exams. And all of the breast cancer surgeons that I know at Presby Dallas, they all just about fell out of their chairs. Because again, the best defense against a breast cancer diagnosis and prognosis that is not good is early detection. And who better to detect their breast cancer but the patient herself? So they all fell out of their chairs, but it didn't mean don't do your self-breast exam. It just means be breast aware. So what does that mean? That means that you should be able to tell your doctor if there are any changes when you do your exam, and then they can follow that with whatever diagnostic testing they need. So some of the signs and symptoms that we want you to look for are a new lump or in the breast or in the armpit, because there is breast tissue that extends out into that area. And there are lymph nodes that are out there as well. If there's any thickening or swelling of the breast, persistent irritation or dimpling of the skin, persistent redness, flaky skin of the nipple or the breast, pulling in the nipple, pain in the nipple, nipple discharge, any change in the shape or size of the breast, and pain in the breast. I guarantee that every single person on this phone call has noticed something at some point in time. For some of us, it's a large part of our anatomy. And if you have a change in that part of your anatomy, does it automatically mean that you have a breast cancer? If you have a little itch or a twitch or a lump or a bump? No. But in order to know if it is something that is to be worried about, it just needs to be followed up by your physician. And so not everything that appears on the breast is a breast cancer. It's an area of skin. And sometimes we see a lot of skin changes. Somebody could get bit by a spider. Somebody can have a little rash. Somebody can have a sunburn. Lots of things can happen, and it doesn't automatically mean that you have a breast cancer, but you do need to make sure that you alert your doctor if there are any changes, because again, you're the best defense against a breast cancer. With regards to family history, so everyone says, well, I don't have a family history, so I'm okay. I don't have to worry about breast cancer. Well, only 20% of breast cancers have anything to do with family history. The biggest risk that you have for developing a breast cancer is having breasts. So don't use your family history to feel artificially reassured that you're safe and that you don't need to adhere to these screening recommendations. Your biggest risk is what we were all given, which is breast tissue, including our males. So every month, in my opinion, should be Breast Cancer Awareness Month, because every month we need to do our due diligence and alert our doctors if we have any changes, get our mammograms, go to our doctor and have a clinical breast exam once a year. Over the age of 75, the decision needs to be between you and your doctor whether or not to continue that screening. If you are a functional 75, 76, 77-year-old, and you are going into your doctor for routine screening for high blood pressure, for high cholesterol, all the other screenings that are recommended at your age, in my opinion, you should continue to screen for breast cancer. Remember that statistic that we have 20% of our breast cancers are diagnosed over the age of 75. It's not a risk to go and have a mammogram. There was some questions years ago about the safety of doing an x-ray of the breast every year. And that has been discussed and studied. And the risk benefit of doing a mammogram, it is considered much safer to have a mammogram every year than it is to take our chances that we get a breast cancer. So it is safe to continue, but make that decision with your doctor. If it's difficult for you to get out of the house, and if it's going to jeopardize your health in order to get your screenings done, you can make that decision with your doctor. I think I wanted to keep it short so that we would have lots of time for questions. You guys are usually so engaged and like to ask lots of questions, which is my favorite part of meeting with you all. Does anyone have any questions? I'm going to switch it back from my screen. Oops.
Dr. Angel, while you do that, I'm just going to let everyone know you've been muted. So if you do have questions, you're going to need to unmute. If you're on Zoom, look for the microphone and tap that. That will unmute you. If you are on the phone, you will need to hit *6 to unmute yourself. And while we wait for any questions, I have one, Dr. Angel.
Sure.
Can you tell us the oldest patient that you have screened and diagnosed with breast cancer?
This was actually within the last year, and she is 84.
Wow.
84. So, and again, if she wasn't coming in for her annual exams and her annual visits, then we would have never found the lump. We would have never sent her for a mammogram. And And she is doing very, very well.
Wow. I see, Ms. Flores, your hand is raised. You want to ask your question?
No, I wanted to let you know that I'm gonna be delivering Meals on Wheels at 10:30. I'm here in the parking lot. It just got complicated for me because I want to be in the meeting and then I have to go deliver the Meals on Wheels.
Okay, no worries. Be safe.
Hello.
I guess she hung up.
No, she's still there.
Hello.
Okay.
I don't know if you can hear me
Yes,
or not.
I think I can.
Yeah, I just joined the meeting probably about 15 or 20 minutes ago. I usually do Zoom, but I couldn't get through. But I heard you ask what was the oldest. What is the youngest?
I have a patient who 32.
Oh.
She did have a family history. So her mother had a history of breast cancer, and I believe a maternal aunt as well. When you have young patients that are diagnosed with breast cancer, it is more likely that there's going to be something about their genetics that makes them at higher risk. But I tell patients when they have a family member who has been diagnosed with breast cancer, the best thing that can happen to that family is everybody becomes breast aware. Everybody should become very, very well versed on how to do their breast exam. They do need to start screening 10 years before that patient was diagnosed with breast cancer. So for example, if you have if that 32-year-old, her daughter should start her screening 10 years before her age of diagnosis, which would be 22. And that is far earlier than what she would do if she followed the general guidelines. So family history applies when it's a young patient. It doesn't apply when it is a patient that's over the age of 50, because we're already doing our screenings at 40. Like my grandmother was diagnosed with breast cancer at the age of 82. And I started my screening with the recommended general population at the age of 40. It didn't change my risk.
That's a great question. Ms. Brooks, I see that your hand is raised.
Yeah, yes, I have a question. Dr. Angel, I want to know if you have a family history of breast cancer. My sister had breast cancer when she was young. Does that increase the risk for my daughters? I'm fine, but does it increase the risk for my daughters?
So we do a lot of genetic testing these days, which is where we draw blood from a patient and we look to see if there are any markers that make their likelihood increase. And you need to have 2 family members that have breast cancer in order to qualify for genetic testing. And it's again, because it's 1 in 8 women. If you have 8 women in your family, if you count up grandmothers and aunts and moms and daughters, statistically, one of you will develop a breast cancer. If it is a patient that is under the age of 50, that's a red flag. So if there's only 1 patient in your family that has a history of breast cancer, that doesn't statistically increase your daughters.
But if there's 2, it does.
If there's 2, then I would recommend that they have genetic testing. Most of it is going to come back normal though. We do a lot of genetic testing, and it's actually very uncommon to have a hereditary cancer syndrome, which is a good thing. Now, if there is a patient with an ovarian cancer or a pancreatic cancer, either of those 2, you only need 1 of those family members in your family to qualify for genetic testing.
Okay, thank you.
And this is with private insurance. I don't know how Medicare works. So if there's those of you out there that are on Medicare, I'm not sure how that works because I'm not a Medicare provider. Medicare is a little tricky. So check with your internist, your primary care, and see if you qualify for genetic testing. But what I always talk to my patients when they want to know about genetic testing, I ask them, what would you do with the information? If you found out that you had a genetic predisposition to breast cancer, would you do anything with it? And if the answer is no, then I don't know that I would do that testing. If the answer is yes, I would be more compliant with my breast cancer screening. Or if you're a younger patient, you would start earlier, then I would do something with that information. But if it's not going to change anything that you're going to do, then you may not want to find out.
Okay.
I have had patients who've had a genetic increased risk for breast cancer who have opted to have a prophylactic or a preventative mastectomy because their risk was so high in their family that they did not want to wait and find out if they were going to develop a breast cancer. They wanted to reduce their risk. And the only way to reduce your risk significantly is to remove the organ that is likely to develop that cancer. And I've had a handful of patients, probably about maybe 4.
That's great information. Ms. Goodwin, I see your hand is raised.
Go ahead.
Yes, I wanted to know, you speak of young men having breast cancer. How do they get examined and when would they know to get an examination?
So with men, it's actually a little easier because let's be honest, they don't have as much tissue to have to palpate. Most of those patients are going to present with a lump. And if there's a lump on a young man's chest or an older man's chest, then they would go through some sort of radiologic examination, not necessarily a mammogram, because a mammogram, we've all had them. They have to take the 2 plates for the x-ray and squish the tissue in between those 2 plates. And with a man, you don't have tissue to put between those 2 plates. So they would probably either have an ultrasound or an MRI or something, and then follow that up with a biopsy. They don't have a regular screening like we do every year. Is that the right thing? I don't know. I think making the men in the family, when they have a family history, have them be breast aware. I think that's probably our best defense against that. Most of breast cancers are not found on that exam that we do in the shower with that little card that was hanging that we used to get from our practitioners. Most of our breast cancers are found when you're shaving or when you're rubbing lotion on or from our partners or something that's done not purposely looking for a lump, but it's usually something accidental. You'll look at yourself in the mirror and you'll see that there's a little raised area or some redness.
Oh, really?
You have an itch. And so most of them are
This
found
is Ms.
accidental.
Purefoy.
Yes, ma'am, Ms. Purefoy. Thank you. Can you mute yourself, Ms. Purefoy? Sorry about that, Dr. Angel.
That's okay.
I see Miss Melinda has her hand raised. Would you unmute and ask your question?
Yeah, hi, Dr. Angel. I just had actually a comment. My dad had a lump. I forgot how old he was. Thank God it wasn't cancer, but his mother, my grandma, had cancer. And so she went through all of the, I guess, chemo, radiation, all that. So I just kind of wanted to make us aware of our men in our lives, But thank God he was okay. But I had never heard of it really or paid attention to it. So it was something that we just kind of wanted to be aware of and be kind of spreading, the word that, they do have lumps and stuff. And he had a biopsy done and everything, but he was okay. But yeah, men, just wanted to put that out there.
Well, and I joke about this every day because I'm a gynecologist. I see women every day. There's a reason why I like seeing women every day. We are much better patients than some of our male counterparts. And my husband, I would throw him into that category. He is not fond of going to the doctor or not being checked out. But we can be examples to the generations below us, and we can, male or female, we can be examples to our nieces and our nephews and our sons and our daughters, that the incidence of cancer, all cancers are on the rise. We We really don't know why that's the case. We think part of it is that our screenings and our ability to diagnose cancer has gotten so much better. We don't know if it's dietary, we don't know if it's environmental, but we are seeing an increase in cancers overall. Part of it is also that we're seeing an increase in longevity, and the longer that you live, the more likely that you're going to have some change that might turn into a cancer. But we need to encourage our males to be better about taking care of themselves. It used to be a struggle to get patients to go in for screening mammograms when I started in practice 23 years ago. I would say now it's rare that I have a patient who has either never had a mammogram or doesn't get them regularly. So we've gotten better. We've gotten much, much better at our screening. Now we need to shift that responsibility to our males.
Hi. Hi.
Go ahead, Miss. Yes, Miss Tiggs, you have a question?
I have a question.
Okay, Miss Pipkins, go ahead and ask your question.
Well, good morning to everybody. I've been
Good
listening. I've seen men that breasts, well, they look like they have breasts, okay? So do they go to a regular female doctor for that, or is there a specialist designed to help men that want to have that removed from them? The breast, or does the breast like that cause on a man, would that cause cancer?
That's usually not going to be breast tissue itself. It's typically going to be just a fat deposit. You know, when we gain and lose weight as women, some of us gain and lose weight significantly in our breasts, and breasts are made up of fatty cells. And so when you see a man that has some breast-like tissue, that's usually just going to be a fat deposit. So a plastic surgeon is going to be the best person to remove that tissue should they want it to be done cosmetically. There's no increased risk for having that tissue other than it be a reflection of your overall health and your well-being. And if you are obese and have breast tissue because of an increased amount of fat in general, then other than that, I think it's more of a cosmetic issue for those men, and they can see a plastic surgeon.
Okay.
I would like to.
Hello?
Yes, I would like to know what age.
I'm sorry.
Can I ask what age for men to be aware? Because my grandsons are in their early 20s, and my son is in his 45. So, what time do they need to look for their breasts? Hello?
What do they need to look for? They just need to, you know, if they're washing in the shower, if they feel anything abnormal, if they feel a lump, then they need to talk to their doctor. Luckily, it's fairly easy to make that diagnosis in a man because there's not as much tissue, there's not as much there. So a lump is going to present itself very easily.
And Dr. Angel, I think she was also wanting to know, is there an age that they should start checking as well?
Yeah, that's what I wanted to know. 20-some or 40-some.
Yeah, well, I mean, I think when I see my young patients that are 18, you know, when you get ready to be an adult and you learn how to, you know, put gas in your car, you have to get your car registered, you have to pay your bills, you have to do all the responsible things as an adult. I think one of the biggest responsibilities to yourself. And so I think when a young man gets to the age of 18 and is going off into the world to become a member of society, one of the things we should teach them as mothers or grandmothers or aunts or what have you is one of the things on the list is make sure you take care of yourself. So I would advise as early as they become an adult. So at 18, I would just make them aware. You know, testicular cancer is a cancer that's common in our young males. And if they're not examining that area because they don't know that they should, then they very well could miss other cancers, not just breast cancer.
Okay. Thank you. Thank you, Ms. Henry, for that question. We're going to go to Ms. Avis Smith, and then Ms. Beverly Tiggs will come to you next. Ms. Smith, you want to unmute and ask your question? You're still muted, Miss Smith.
Can you hear me
There
now?
you go. Yes.
Okay. My question is more personal. I wanted to know, I know she's not an oncologist, but is there such thing as, a person having breast cancer and maybe other cancers too?
There is. It's rare to have more than one primary type of cancer, but that certainly is a possibility. A lot of times, if you have breast cancer and then later on develop another cancer somewhere else, it's a possibility that the breast cancer could have come back and now it's affecting another organ. An interesting story. I have a family history on my kids' dad's side, and I wanted to know what their family history was because I'm interested to educate my kiddos. And they had always told me that my husband's grandmother had died of lung cancer. And I thought, wow, isn't that interesting? She never smoked. She was fairly healthy. And I said, are you sure it was a lung cancer? Knowing that I needed that history for my kids. And they said, well, she did have a breast removed about 5 years before that. And I said, well, then it's probable that she had breast cancer. And then when it came back in her lungs because the lungs are a common site for metastatic disease. The bone marrow is another place, the brain is another place, and the liver is another place. So sometimes you have to piece it together like a puzzle to find out what the primary cancer was. And when it comes back, it looks like it's a new cancer, but it's the same. Does that make sense?
Yes,
Does that
ma'am.
make any sense? So now I know that I have a family history of breast cancer on my grandmother's side, and also in their great grandmother. And so when my daughter becomes of age, I will probably talk to her about doing early screenings.
Okay, thank you.
Ms. Tiggs, do you want to unmute and ask your question?
Am I unmuted?
Yes, ma'am.
I found my lump in my breast in 93, and I had my surgery in 94, and I lost one breast. And so that all this time up to now, even now, I've still been cancer free. And I had my surgery at Parkland, and because I had 2 aunts and 2 first cousins, they did the BRCA gene tested on me, so because I wanted to tell my daughter, and my test came back where I didn't carry the gene.
That's wonderful.
I gave that information to my daughter.
Well,
but I'm still cancer free. I just lost
wonderful.
one.
Congratulations.
I lost one breast.
Well, currently, I think the latest number, if I'm not mistaken, there are about 30 some odd genes that have been identified in families. And the more testing we do, the more that we're going to find more genes. Back in the 90s, they might have known about BRCA1 and BRCA2, but now there's a whole host of other genes that may increase risk for other types of cancers, not just breast. An interesting story, I had a patient who had family history of breast cancer. We went and did a genetic test on her, and it came back that she had a higher incidence for colon cancer. She was in her 40s and was not recommended to start her screening colonoscopy until the age of 50. But we, based on that knowledge, had her go for a colonoscopy, 41, 42, and they found polyps. And so the screening for her breast cancer history actually led to an early diagnosis of a polyp that may or may not have turned into a colon cancer. And the more families that we put into the database, the more testing that we do, the more history we gather, the more we're going to be able to piece together some of that information and be able to help generations to come.
Thank you, Ms. Tiggs, for sharing your story. If you're on the phone and you have a question, please, by all means, unmute yourself by hitting *6 and ask your question. Or if you're on Zoom, raise your hand and we'll get to you as well. Let's see. Ms. Smith, I see you have your hand raised again. You have another question? You're muted if you'll unmute yourself.
Yes, ma'am. I don't mean to take up all the time, but is it, I mean, I often wonder how is it possible to have lung cancer if you never smoked? Or, you know, I've been around a lot of smokers.
Yeah, it's rare, but it's possible.
I can attest to that. I'm Shirley Jones. Can you hear me?
Mm-hmm.
My mother passed in 1970. She never smoked. And initially she had breast cancer. The doctors told us she would live 30 days, but they were wrong. We took her to Mayo Clinic and she lasted 7 years after the diagnosis. The breast cancer, her breast was removed, but at 7 years later, she had metastatic breast cancer of the lung. And cancer is a very mysterious disease. And in that I have 2 sisters now. There were 4 girls. One passed away with skin cancer. And the 2 other sisters, one has bone cancer now, and the other had breast cancer, but they're both doing unexpectedly well for what they had. And I had that gene test at UT Southwestern about 10 years ago, and it skipped my DNA. So my mother never smoked. She didn't drink. And she was only 60 years old when she passed away. And my younger sister was 54, the one with the skin cancer. So it's a most devastating illness to have.
It is. I'm so sorry for your loss.
Ma'am?
I'm so sorry. I know it was a long time ago, but losing your mom is very difficult. So the good thing about diagnosis of cancer in 2021 is that we have an amazing way of treating cancers. We've gotten so much better with our screenings, but also treatments are not as are much more successful. And so I tell patients when I have to make that phone call, which I have to do on a fairly regular basis because I take care of women every day. And when I make the phone call that their breast biopsy has potentially come back with a cancer, that I tell them, you know, but this does not mean that this is a death sentence. This does not mean that you're going to die of this disease. This just means that we're going to have to fight. It means we're going to have to go through some yucky things. We're going to have to potentially have surgery or the chemicals of chemotherapy. But this is something that you're going to add to that 4 million breast cancer survivors. And I think knowing a survivor, probably all of us know a breast cancer survivor if we have enough women in our lives. Now making that phone call and making that diagnosis is not as doom and gloom as it used to be because we've gotten so much better. Connie had, Constance had asked about describing what is cancer and how do we get it. And It's not specific to cancer of the breast, but by definition, cancer is when the DNA of a cell is affected by something, makes it abnormal. For example, in skin cancer, sunlight damages our cells. We've all gotten a sunburn. We've all been out in the sun because we live in Texas. But why don't we get cancer? Why don't the damage of that sun affect all of our cells? And it's because most of that damage that occurs can be repaired. And if we repair the cell, then the cell goes back to normal. Some of those cells, when they become damaged, never repair themselves. And if that damaged cell becomes 2 damaged cells, becomes 4 damaged cells, and so on and so on and so on, that's what causes a cancer. And they grow faster than the normal cells. They demand more of the resources, the fuel and the energy from the body than the normal cells. But that's actually how we get chemotherapy, a lot of chemotherapies to work on cancers. Chemotherapy stops rapidly dividing cells, which is what a cancer is. It's growing at a rapid rate. And so most of our drugs are targeted towards cells that are growing fast, which is also why the side effects of chemotherapy affect other organs that are growing rapidly. Our mouth regenerates cells. It's one of the fastest healing organs in our body. So a lot of patients with old chemotherapy agents would have a lot of mouth issues. They would have ulcers and pain and things like that. A lot of our cells that line our gastrointestinal system, our colon and our small intestine, are also rapidly dividing. So all the rapidly dividing cells are affected equally with some of the chemotherapy medicines that we have. So the genetics, we talked about our genetic risk. That's how that plays into repairing the damage of those cells. If you don't have a certain gene, you might not be able to repair that damage.
Do you see my little hand fan in
So I see Miss Donna Robinson has her hand raised and Renza Lewis. And so we're going to go in that order to ask some questions. Miss Robinson, would you unmute?
Oh, where'd she go?
Miss Donna Robinson.
Okay.
Miss Donna
Thank
Robinson.
you, Melanie. Yes, can you hear me?
Yes, now we can. There you go.
Can you hear me?
Yes, ma'am.
Okay. Thank you, Melanie.
You're
Dr.
welcome.
Angel, I have, but you kind of answered that already just then. My mother had metastatic ovarian cancer. And she, every year, faithfully, always had her pap smear. And then now recently, she did use that talcum powder, and they had to, she got sick, and I think they found polyps first, and then they said she had to have a hysterectomy. And I always wondered about that because they never had a positive test results from her pap smear. But my sister died with breast cancer. It metastasized at the age of 42. 37. And I was wondering, since I have to have 2 in the family, does that mean I need to alert my daughters and my granddaughters to get this BRCA testing?
If you have a breast cancer and an ovarian cancer on the same side of the family,
yes, ma'am.
And then they can talk to their doctors of whether or not they should have that genetic testing done. It depends on what would they do with that information. Would they want, if they found out that they tested positive for BRCA, and that put them at a higher risk for breast or ovarian cancer, would they elect to remove their ovaries? Depends on their age. What if they're 20 years old and they haven't had kids yet? They
Yeah,
might
they're
not,
all young. Yeah.
they might not want to do that. So you have to always look at what is the purpose of doing that testing? What would I do with that information?
Well, I was thinking what you were saying earlier, if we know early. Now, when my sister passed, they didn't have as much research done at that time as they do now.
That is correct.
And my mom, they didn't have all this new stuff either. But I was thinking that you said the earlier it's detected and you get on it, the better your chances are to go through it.
Absolutely. So if anything comes out of the discussion about your family history, they should be very good about going in for their annual examination with their OBGYN or their primary care physician. They should be breast aware, know how to check their breasts and what would be something to let their doctor know about. And then when it's time for them to have screening mammograms, they should be compliant with that. So our family history can help us to stay on track and to have screenings when it's recommended.
Okay, thank you very much.
You're welcome.
Thank you, Ms. Robinson. Miss Lewis, we're going to go to you, and then Esther Mays has her hand raised, so we'll go to you after Miss Lewis, Miss Mays. Go ahead, Miss Lewis.
Yes, I'm just wondering, is breast size determining?
Did anyone hear the question?
I think it was about breast size and does it have an effect or determine?
It doesn't increase your risk for breast cancer, but it does make it more challenging to do an exam.
Yeah.
I think it was about breast size and does it affect or determine?
Yes.
Does it increase your risk for breast cancer?
Miss Lewis, are you still there with us?
Maybe she can type the question in the chat.
That's a great idea. Miss Lewis, could you type your question into the chat?
Oh, okay.
Okay.
Yeah, so breast size doesn't, I think that was the question. So breast size doesn't increase or decrease your chances for getting breast cancer. It is a little easier to feel a lump when you don't have much tissue, kind of like a male. It's a little bit more challenging when you have more tissue because you have to do a more thorough examination. But statistically, there's no difference. One breast cell is all you need to develop into a breast cancer.
That's a really good question. Miss Mays?
Good morning, Dr. Angel. I want to say that I'm really enjoying the webinar, and the information is always informative to learn more. But I was diagnosed with intraductal carcinoma about 13 years ago, and it was caught really early, and it had to have just a portion of the tissue removed in one breast. And I'd like to know, and ever since then, I've had my follow-up mammograms religiously every year, and had the recent one was last month. But I want to know, and I had radiation and didn't have to have chemo, and I want to know, what is the significant difference in having radiation versus chemo?
Well, congratulations on being a breast cancer survivor. That's wonderful.
This is Georgia Bell.
One moment, Ms. Bell. We're going to come back to you in just a moment.
So the difference between treatment is going to be determined by the stage of the cancer. So there's two different things that we get when we get diagnosed with cancer. We get the type of the cancer, whether it's ductal or lobular, which means what cells it came from. And then depending on how big it is and if it's spread outside of the breast into the lymph nodes or other organs, that gives you your stage. When you have a cancer that is a lower stage, like stage 1 is typically confined to the breast and it's a very small, sounds like that's what you had.
I think that if I'm not mistaken, she said that it was about the size of a dime.
Okay.
And I had lymph nodes removed from that particular breast. And could the cancer come back in the other breast? Is it possible?
That's why you're still having your screening mammogram.
Okay, so everything has been good, you know, from the first time that I was diagnosed in 2007 up until 2021.
The only time you don't have to have screening mammograms is when you've had both breasts removed and there's no breast tissue to do a mammogram on.
Okay.
But since we still have breast cells and you still have breast tissue, getting your mammograms is still going to be recommended for the rest of your life.
Okay, well, good.
But you're a testimony of how early detection transformed your result. And here you are all these years later.
Exactly. Yes. Well, thank you so much.
You're welcome.
Miss Bell, Miss Georgia Bell, if you'll hit *6 so that you can unmute and we can hear from you. Miss Georgia Bell, hit *6 on your phone so we can hear from you. You're muted right now.
You hear me?
Yes, ma'am, we sure can.
Okay, I said I'm a 40 years of breast cancer survivor. I took chemo 2 years. I had both my breasts taken off. And I have 3 sisters had breast cancer. I had one sister passed and other 2 sisters, they had breast cancer. And cancer run down through my family. My nieces and nephews had cancer. And so I'm a 40 years breast survivor.
That's wonderful. Congratulations.
Okay. That's all I want you to know. And I had no more problem. I don't take the mammogram. I take 6 X-rays today. And that's about all I want them to know.
Thank you, Miss Bell. Congratulations. Does anyone else have any questions? Again, if you're on the phone, you can hit *6 and that will unmute your line.
Dr. Angel, you good on time?
I have about 2 more minutes and then I have to get back to work.
Okay.
Sorry, ladies.
That means it's last call for any comment or question.
I have a question. She was saying that with the testing that they do, I can't remember what the name, but that it's they will do the test as a result of what you plan to do with the information. Well, would the information always be that the breast or the tissue or whatever would have to be removed, or is there anything in between?
Well, you can increase your screening. For example, that patient who did the genetic testing because she was worried about her risk for breast cancer, it identified that she needed to have a colonoscopy earlier than what she was planning. She was planning on doing her routine screening starting at the age of 50. And because that genetic test came up, she did it at 40 or 41, and they actually found a polyp. So sometimes that information would increase your screening and make you go and have your colonoscopy that you've been putting off, or go and have your mammogram that you've been putting off. So it can be more than just removing that organ. That's one of the options if it's an unnecessary organ. Sometimes it's an increased risk for some cancer that you can't remove. So you usually will have genetic counselors that will go over those results with you, give you what do you do with that information, and they are the ones who will guide what you do after you get that testing done.
No, okay, thank you.
Thank you so much, Dr. Angel. This has been so helpful, so informational.
Yes, we have.
We thank you for your time. We know you're busy, but each time you've come and spoken to us, I think we've all come away with so much more information and feel better informed about how to take care of ourselves and those that we love. So thank you tremendously for your time.
Melody.
Yes.
Melody.
Thank you so much.
Hello.
Yes, ma'am, Ms. McAfee. Bye-bye, Dr. Angel. Ms. McAfee, did you have a comment?
Yes, I've been trying to speak, but I couldn't get in. You know, I at 73, well, I guess I was about 71 when they diagnosed me with lung cancer. They wanted me to do chemo, but I didn't want it because my sister had a hard time with it. So I decided to take the pills. And that was in 2018. But since I've been on the medication, I've been doing good, better than some of the people that's in stage 4, and I am stage 4.
Oh, wow.
Yep.
Thank you for sharing that, Ms. McAfee.
I've been trying to hit this, but I think I was hitting it wrong. I think I was doing pound 6 instead of star 6.
Oh.
I'm sorry.
That's okay, but I'm glad you got through it and were able to share with us. Thank you so much.
Yes. Yes, ma'am.
Well, that actually concludes our presentation today. I hope that you all took something away that was helpful, that you can share with other people that you know and love, and that also will equip you to make sure that you're taking care of yourselves and screening yourselves as well. I did not know, the prevalence of cancer, particularly breast cancer, as we age. And so that was news to me. So I'm thinking about that and also just screening as well. But thank you all for joining us this morning. And that will conclude our presentation for today.
All right.
Well,
you have a good day.
Have a good day.
I enjoyed it, and we'll see you next time.
And thank you to all the foster grandparents who joined us this morning.
All right.
Thank you for having
Bye.
us.
Yeah, thank you, Melanie. Thank you.
Thank you, Melanie.
You're welcome.
Thank you, Melanie. Bye-bye.
Great
Bye-bye.
Bye.
Thank you, Melanie.